Yes.
Yes, it's okay. Thank you. And good evening. My name is Marta, and like it introduced me, I work in Latvian Oncology Center. A little bit problem and 1 minute. For today, I want to introduce with my presentation and clinical case. And this presentation, I also include information on anatomy. I would like to point out that many of these images are designated as visual aids that I show to my patients also. This helps to educate them about the pelvic floor musculature and its functional significance, ensuring they fully understand that we will be training and how we will be doing this. I also use these materials during the preoperative consultation to educate patients about potential functional issues and the possible preoperation physiotherapy. In my opinion, this is crucial since we cannot see the action of this muscle and they are difficult to palpate. We must provide the patient with a clear visualization. And today I want to give you a huge information, and let me start it right now. And we start with the basics. What exactly is a prostate? The prostate is a small gland that is a part of male reproductive system. It is located just below the bladder, in front of the rectum, and it surrounds of urethra, the tube that carries urine out of the body. The main function of the prostate is produce fluid that nourishes and protects sperm. This fluid mixes with sperm cells and forms semen. Although the prostate is a relatively small organ, about the size of walnut, it plays a central role in male fertility and urinary function. Prostate cancer is often silent in its early stage. Most men do not notice any symptoms. As this disease progresses, however, patients may start to experience certain symptoms. The most common are urinary problems, such as frequent need to urinate, especially at night. Some men may notice blood in the urine or semen or difficulties with erectile function. In more advanced cases, pain can appear in the back, hip, or chest. There may also be numbness in legs or feet and even problems with bladder or bowel control. In men, prostate cancer is the most common type of cancers. Another important point is a trend we are currently seeing. Prostate cancer is no longer only a disease of older men. More and more cases are being diagnosed in younger men as well. This makes the topic especially relevant when we think about prevention, early diagnosis, and rehabilitation. This figure leads us to believe that we will need a large number of physiotherapists working in this area. Quite often, when we think about the pelvic floor, the training course and materials out there are most frequently designed for the woman. That is a problem right today. And now I would like to share a clinical case. The patient underwent surgery in September 2025, and first I met him in October. Due to elevated PSA levels, the patient underwent diagnostic investigation, which confirmed prostate cancer in a localized stage. No distant metastases were detected. Radical treatment was indicated, and the patient consented to surgical management. The patient was informed about the expected outcomes, the treatment process, and the postoperative period. Planned surgery was radical prostatectomy with bilateral regional lymphadenectomy. The procedure was scheduled for early September. After surgery, the doctors did more tests. They found a few cancer cells very close to where the prostate used to be. Because of this, patients will need radiation therapy. However, he does not have to start it right now after surgery. The doctors will watch his health closely and wait for the best time to begin. On this slide, we can see the main steps of radical prostatectomy that are particularly important for us physiotherapists. First, we notice the surgical incision. This immediately reminds us the scar will be present and we will need to assess and address it during rehabilitation. Next, part of the rectus abdominis muscle dissected. This makes us think about the potential impact on the abdominal wall and how this may affect overall core stability and function. A very important step is the removal of the prostate itself. During this procedure, ligaments is detached. As a result, the bladder will be positioned lower than before. In this image, we see the prostate being separated from the urethra. This has several implications. Nerves and muscles are affected, and the functional length of the urethra is reduced. All of these surgical aspects directly influence the challenge we need to consider in the physiotherapy process. And also, during this surgery, lymph nodes on both sides will also be removed. This increases the risk of fluid buildup, which can cause swelling. Because of this, we need to pay close attention to changes in size. We also need to teach the patient what to look for and how to take care of it. The internal urethral sphincter is smooth muscle structure localized to the bladder neck. Its primary function is to provide involuntary control of urinary continence by maintaining closure of the bladder outlet at rest. During radical prostatectomy, the bladder neck and surrounding tissue are surgically dissected, which may partially or completely compromise the internal sphincter. Damage to this structure reduces the passive involuntary mechanism of continence, placing greater demand on the external urethral sphincter and pelvic floor muscles. As a result, patients may experience postoperative urinary incontinence, particularly in the early recovery phase. Rehabilitation strategies, including pelvic floor muscle training, aim to strengthen the external sphincter and compensatory mechanisms to restore continence. During the radical prostatectomy, the anatomical proximity of the prostate to the urethral sphincter makes it highly susceptible to surgical impact. The external urethral sphincter, located just below the prostate apex, may be partially damaged or weakened during dissection or removal of the prostate. Even with nerve and sphincter sparing techniques, structural and functional compromise of these structures can occur. Physiotherapy and pelvic floor muscle training play a crucial role in rehabilitation by compensating for the weakened sphincter function and supporting continence recovery. After prostate surgery, the external urethral sphincter becomes the primary structure responsible for urinary continence. When patient came to me, it was October. He reports stress urinary incontinence during physical exertions as well as loss of erectile function. At night, he wakes up 3 times to urinate. In his daily life, the patient is physically inactive, his body mass index is elevated, and he presents with abdominal obesity. An examination, the postoperative scar is firm and rigid. An ultrasound assessment of pelvic floor shows reduced muscle strength, only 2 of 5 on the grading scale. Patient is 58 years old. Because of limited physical activity and proactive behavior around the scar, the patient has developed scar tissue thickening and rigidity. The lack of mobility and avoidance of local stimulation likely contribute to the formation of adhesion and reduced tissue elasticity. To address scar tissue problems, several physiotherapy methods can be applied. First, soft tissue mobilization techniques, including gentle massage and mobilization, help improve tissue elasticity and circulation. Second, silicone patches or gels can be used. They are effective in reducing thickening, decreasing itching, and regulation of collagen synthesis. Also, if it is possible, we can think about physical procedures like ultrasound or shockwave therapy, but this is a little bit. We need time 3 months after surgery, and we need to consultation with a urologist about this question. Rectus abdominis diastase after prostate surgery is not a very common complication, but it may occur several reasons. Like in my case, the surgery was performed through a larger abdominal incision. The patient already had a weak abdominal muscle or was overweight prior to surgery. And in ultrasound, we also see that rectus abdominis diastasis is in this case. Intra-abdominal pressure is a pressure inside the abdomen. It is created by the abdominal muscles, diaphragm, and pelvic floor working together. This pressure naturally changes during daily activities. Normally, when intra-abdominal pressure rises, the pelvic floor and sphincter muscles contract to compensate, which maintains urinary continence. In my clinical case, when intra-abdominal pressure rises, the pelvic floor fails to compensate, leading the urine leakage. To address this, the patient is performing target exercises to strengthen the anterior abdominal wall along with breathing exercises. A key focus is coordination, these movements with pelvic floor muscle activation. Trans-abdominal ultrasound is non-invasive method used to evaluate pelvic floor function following prostate surgery. And also we can use transperineal ultrasound. It enables assessment of bladder filling and emptying dynamics, pelvic floor muscle contraction, and potential post-void residual urine. The examination provides objective data on muscle strength, coordination, and compensatory mechanisms, supporting both clinical decision-making and physiotherapy planning. In this particular case, pelvic floor muscle strength was assessed at 2 out of 5 on the grading scale. Avoiding diary is a simple yet viable tool for the assessment and management of urinary disorders. Patients are instructed to record the frequency and volume of urination, episodes of urgency, incontinence event, fluid intake, and nocturnal voids over several days. In my patients, I also say you can use this diary 2 to 3 days for the better results, and this I also give in the first consultation, and they send me to email this back, and then we to change tray. In my clinical case, after completing bladder diary, the patient was surprised to see that they would actually hold longer volume without leaking. This encouraged them to try waiting longer between bathroom visits. The diary revealed frequent voidings of small amounts. The patients explained that they were doing this simply just in case to prevent accident. This helped establish a healthy fluid intake and regular voiding schedule. The International Prostate Symptom Score is an important tool for evaluating urinary symptoms in men with prostate condition. It allows us to measure the severity of symptoms such as frequency, urgency, weak stream, or nocturia in standardized way. Using this tool is not only help us understand the patient baseline condition, but also allows to monitor changes over time and assess the effectiveness of treatment or rehabilitation. In this way, this tool provides both patient and clinical with clear, measurable feedback about the progress of care. Physiotherapy can be initiated already before surgery, like rehabilitation, to teach breathing, circulation promoting exercises, and correct pelvic floor activation. After radical prostatectomy, pelvic floor training is usually started as soon as the urinary catheter is removed. Commonly, it is 1 to 2 weeks postoperative, provided there are no complications and no wound is healing well. Currently, our doctors are also trying to remove the catheters earlier upon the patient discharge from the hospital. Approximately it is 3 to 5 days after surgery. This strategy also shows good results, which do not negatively affect the patient's sexual functional status, and it allows for earlier gradual initiation of pelvic floor muscle training. Importance of proper breathing. Diaphragm and pelvic floor works in synergy. Correct breathing reduces unnecessary intra-abdominal pressure, prevents excessive load on bladder and urethral sphincter. Pelvic floor muscle awareness. Patient must first learn to identify and consciously activate pelvic floor muscles. Awareness ensures correct contractions and prevent compensatory by surrounding muscles. With this patient, we start first 4 meets. When we meet consultations, we start with only pelvic floor with breathing, and after 4 sessions, we start with dynamic exercises, with loads, with high intensity trainings. When we show that when we see the patients have a good contracts of pelvic floor muscles and intra-abdominal pressure was under control. Optimization of pelvic floor contraction. The goal is not only voluntary control but also automatic activation. Training should include contraction during situation of increased intra-abdominal pressure, like coughing, sneezing, lifting, changing positions, physical exertions. Optimization helps restore continence in daily life without conscious effort. And this start in, like I say, in 5th session. A frequent error is performing exercise only in static positions. It's like lying or sitting. This does not successfully improve pelvic floor muscle functions during movements. Training must be integrated with movement and daily activities. Contractions should be practiced during standing, walking, lifting, sneezing, and physical exertions. Urinary incontinence is common immediately after surgery. The bladder and pelvic floor muscles need time to adapt. And this is also information which we need to tell our patient and explain. Many patients notice gradual improvement in urinary control within the first 3 months. Regular pelvic floor muscles exercise significantly support recovery. On this slide, we can see several types of medical devices that may help in cases of urinary incontinence. These include diapers, absorb pads, which are the most commonly used. There are also condom-time urine collectors, which can provide an alternative solution for some men, and also finally we see the penile clamps, which are sometimes applied to temporarily control leakage. All of these devices can play a role in managing symptoms, but our goal in rehabilitation is always to reduce the need for them whenever possible. In January, when patient come to me, he reports that they get up to use a toilet once a night. Also, assertionally, they can sleep through the entire night without waking. Mild urine leakage persists during high physical exertion, such as intensive snowshoeing. When he goes out, they use urinary incontinence pads with lowest absorption level only for security purpose. Sexual rehabilitation should be considered as a part of recovery if it's relevant to the patient. Early initiation helps preserve erectile tissue health, improve blood flow, and support the return of sexual function. In cooperation with urologists, pharmacologic treatment may be prescribed to enhance penile blood circulation. Medication is often started shortly after catheter removal, depending on healing and absence of complications. Use of vacuum erection devices recommended as non-invasive method to promote penile blood flow and prevent tissue fibrosis. Frequency usually advised is daily or 3 to 4 times per week for 5 to 10 minutes, even if sexual activation is not attempted. Can be used together with pharmacological therapy for better outcome. And my patient uses vacuum erection device and also cover jack injections, and they had a good result. In post-treatment outcomes, muscle strength, pelvic floor muscle strength improved from grade 2 to grade 3. And this is results. Sexual function is partly restored and the patient is satisfied with the result. Nighttime voidings, it's maybe he don't go sometimes, but waking at night was reduced to maximum of once time per night. The scar is no longer hard. It has become elastic and does not interface with daily activity. The patient no longer feels a tearing sensation. The patient successfully controls intra-abdominal pressure, but his body mass index is not improved. Active stability in pelvis has improved, and the patient can effectively coordinate muscle work during physical exertions. In March, the patient was informed that radiotherapy is scheduled to begin in June. In physiotherapy, we initiated education regarding potential complication of radiotherapy and the physiotherapy options available for their management. As the patient begins radiotherapy, we must anticipate several potential complications. Radiation can worsen urinary issues, leading to incontinence, strictures, or painful radiation cystitis. Patient may also face bowel urgency from proctitis and high risk of erectile dysfunction and severe radiation fatigue. Furthermore, previous lymph node removal increased the risk of pelvic fluid buildup, lymphocele, and painful swelling in the lower lymph like lymphedema. However, this is exactly where we pivot our approach. It responds to these three emerging challenges. We will set new physiotherapy goals and adapt our interventions. Our primary mission is to proactively adjust our treatment so the patient can successfully manage these symptoms and maintain the current functional status throughout the entire course of radiotherapy. Our rehabilitation approach before radiotherapy focuses on four key pillars to minimize side effects and improve treatment accuracy. It will be mindful breathing, deep breathing techniques, preserve pelvic floor elasticity, and maintain tissue mobility, preparing from irradiation. fluid intake, instruction patients on regular water drinking pattern issues and stable bladder volume for every treatment session, regular toilet visits establish a strict, consistent voiding routine, simple relaxation techniques reduce stress, and crucially, muscle tension in the pelvic area, making the treatment delivery smoother and more comfortable. By educating our patient on these 4 habits, we improve them to actively participate in success of their treatment. And thank you for being with me today.